Good afternoon, Chempakans. Welcome to another episode of Cempaka at Home webinar series. This is episode number 4, coming to you at 3 p.m. Friday, the 4th of April. Is it the 4th of April? No, it's the 3rd of April. We are losing track of time here in this extended RMO Part 2. So this particular webinar series is very special. We are joined today by Dr. Lao Jiaying, Harimau, class of 2011 from Cempaka Cheras, who is now serving in Pusat Perubatan University, Malaya. Dr. Lao Jiaying, can you tell us a bit more about yourself?
Hi, good afternoon, guys. I'm Jiaying. What Dr. Encik Hisham said, I'm class of 2011, Harimau from Cempaka Cheras. After completing my 5 years in Cempaka Cheras, I went on to do A-levels and subsequently spent 5 years in Dublin, Ireland, in Trinity College and completed my medical degree there. Then I came back here and started practicing in University Malaya about a year ago. So I have been a junior doctor here for about a year. So I think that's about it. I'm currently in orthopedics, so basically bone doctor, but I have been basically deployed to emergency department for the past 2 weeks for this period of crisis. Yeah.
Okay. All right. Thank you, Jiaying. So, many Chempakans that remember you from Cempaka Cheras remember you for your great interest in broadcasting and the videos that you did for the many box office productions, for example. What is the reason behind your sudden interest in medicine and caused you to go into that field?
Actually, I suppose I've always had interest in science in particular. So that's why I chose science stream to begin with. In particular, in science, I think the thing that got me really interested was really biology, but in particular the human part of biology, physiology and anatomy, that kind of thing. Because in A-levels, I think that's where it really blossomed, because what happened in A-levels was we had several projects that we had to do, community projects. So in that period, we did some community work and I shadowed doctors. And at that time, I realized, also together with my family's situation at home, I realized that medical practitioners actually make a big difference in people's life, and not just the people that they are treating, as in not just the patient themselves, but in general, the whole family that is involved. So I really got really interested, especially in surgery, where people can go in horizontally and really walk out of the hospital. So I just think it was I was just really attracted to it since then.
That's really good to hear. Okay, let's get into the main topic that we want to talk about, the COVID-19 pandemic and the current RMO that we are in right now in Malaysia. So all of us, normal rakyat at home, felt the difference on the 18th of March, at the very first day of the RMO, the Restricted Movement Order. When did your life turn upside down because of this pandemic as a doctor?
Okay, I think because the virus itself was not something that was developed overnight. The thing was started, as in like first case was reported back in last year, around the end of last year. So there were already a bit of like just whispers and like small saying, just whispers really, around like even the week before actual RMO being implemented. However, I think we didn't really actually feel the difference, because at that point, University Malaya, which is SMPPUM, the hospital that I was working in was not a COVID cases accepting center. So we don't actually accept COVID cases, and we are not like a primary infectious disease center like Hospital Sungai Buloh. So at that time, we didn't actually feel much of a difference up till, like you say, around the start of RMO. I think that's where we actually felt it as well. So at that point, we started, I think overnight, we had a few notices over a few days, I think. Notices that were basically informing various departments that basically try our best to get the patients to be discharged. so long as they are medically fit to be discharged, and try to backlog their clinics and that kind of thing, and like push back elective procedures. So I think that's where we started to really feel it coming. And then there were a period, I don't actually remember when, I think it's about 2 weeks, a bit more than 2 weeks ago, we started to have people being quarantined, as in like staff being quarantined, and due to exposure, whether or not in the hospital or like somewhere else. So that's where people were deployed to cover emergency departments like myself. We were sent to emergency department, and like the work that we usually do in the wards were changed. So our roles basically swapped slightly. So yeah, I think that's where we really felt it about 1 week into RMO actually. Yeah, in terms of in the hospital setting.
Okay, can you tell us a bit about your day-to-day duties now in University Malaya?
Like now, as in during RMO or
during the RMO? Yes, during the RMO.
Okay, so during RMO, in order to curb the spread of the virus, I think most hospitals, including ourselves, we have a booth outside the hospital in the outdoor area. That is so that whoever that's going there immediately gets triaged before entering the hospital complexes itself. So people with any kind of symptoms of fevers, any symptoms of a cold or flu, any airway issues, we immediately screen them at that point. Or if they have a fever, or if they have certain features that is suspective, we will immediately bring them out aside, and they would be going through a separate pathway. And for housements, we are actually in the emergency department where we are dealing with people that may have came through that first line of triage, but was not unfortunately, either they were not telling the truth, or when they went through triage, they somehow managed to slip through the triage. So then we see them. Because for cases that were clearly, like frankly positive, like cases that were people having like, severe fever, coming back from like public and stuff like that, they would immediately be pushed to the side, and medical officers and specialists would be seeing them, because we just frankly don't want so many people to be in contact. So they would see them by themselves and only one person. So if something were to happen to them, it will be one person that's out and not the whole team. So currently what we're doing is basically seeing patients, finding out why they're here, taking their bloods, setting a line, giving them whatever initial management that they need, and pass it on to like whichever team that needs to see them next in the department.
Okay. Do you see in the last few days or weeks a rise in the number of people coming in, or is there anything you can comment on that?
Okay, so PPUM, we are one of the 3 hospitals that are taking in COVID cases. So we are primarily a COVID hospital now, along with HKL and Sungai Buloh. So the three of us, we share a common similarity whereby we try our best to push back our elective cases, like I said earlier, and patients that were to come into their clinic and stuff like that will also be pushed back. So in general, I think our hospital has quieted down a lot, frankly. However, people who are coming in now, which is like, coming in through emergency department, they, in a way, they are, I suppose we have to presume that each of them is positive one way or the other to protect ourselves. So I think resources are more concentrated in that regard. However, in terms of general number of people coming in, I think it has reduced by a lot. Just like, I think an example would be, because I'm in orthopedics. So because of the RMO, there are a lot less cars on the road. People are all at home. So in a way, there were a lot less car accidents. There were a lot less falls, elderly falling. So yeah, we have a lot less patients, even in that emergency kind of standpoint. So yeah, I hope that answers the question.
Yeah. Okay. Can you comment a bit on the case management of a COVID-19 patient? Okay, let's say someone who is admitted, they are tested positive. What happens to them next?
Okay, I think first of all, we need to specify when we say patients that are admitted for COVID. So if someone were to be admitted, say if your friend tells you that they are admitted for COVID, it might not mean that they are definitely tested positive. So even if patients that are not tested positive yet, but say if they cannot be safely quarantined at home for whatever reason, or if they are in a high risk group, for example, in the age of elderly, so more than 65 years old, or like really young patients, like 1 year old, a few months old, they will automatically qualify to be admitted as well, even if they are only being currently investigated for. And also patients that are that has like having various medical conditions. So if they have like a weak heart, if they have had asthma in the past with a lot of smoking history, we will also admit them because of high risk group. Because patients with if they're tested positive, it takes a while to run the test actually. A lot of people don't know that, but it takes a while. It takes a few hours, and we only run it twice a day on weekdays. So if you miss the day, the timeline, you might actually have to wait for like 24 hours or so to get your test result. So those people will be admitted as well because of how fast they can deteriorate if they are actually COVID positive patients. Now, patients that are actually tested COVID positive, they are kept in several wards that are in our hospital. So we generally split them into 5 categories. However, as of now, I think as of my last reading this morning, there's still no actual, I suppose, management that has evidence that truly makes a difference. So it's basically the same as any virus, such as dengue. Yeah. So such as dengue. What we do in general is we keep them hydrated. We keep their vitals stable as much as possible. So when I say vitals, I mean we keep their blood pressure, we keep their heart rate, and every parameter that we can logically test for, we keep them as physiological as possible. That means as much close to the baseline as possible. Then we make sure that if they have any symptoms, we support those symptoms, and that's basically the full management. However, there are some off-license use medications, and there are some ways that we can stratify them into if we need to do anything more. So currently we split them into 5 categories. So the first grade, which is the I suppose the weakest one, the mildest one, would be asymptomatic, and that actually happens for most people. So most people are actually asymptomatic or very mild symptoms. You barely break a sweat. You can be as mild as just having some muscle ache, loss of appetite, and we even have cases of just patients having like overnight develop a loss of sense of smell. So they just suddenly overnight cannot smell what the mother was cooking. Even as mild as that. So for those people, we generally don't do anything. We monitor and make sure that they are well. After 2 tests of swab negatives, we can discharge them back to the general public, so long as they have resolved all their symptoms. Then we come to the next group of people with pneumonia. So the issue with SARS, as in SARS-CoV-2, is that you can develop a pneumonia, which complicates the whole scenario, which really puts a lot of strain to your lungs and in general your whole cardiovascular system. In these people, we might need to treat more how should I put this? We might need to treat it more aggressively with medication as well. And then we come to the next group where you actually need oxygen support. So that means you don't just have pneumonia, you have pneumonia and you actually is suffering from the ability to exchange oxygen. So in these people, we actually need to give them supplemental oxygen. So either by a face mask or some kind of a thin tube that can deliver a small amount of oxygen, just to keep them comfortable. And then we have the really small percentage, but unfortunately it happens, is the group that develops multi-organ failure, requires ICU admission, and unfortunately they may not make out of it. So those tend to be either the people with a lot of comorbids, so people with not very good heart to begin with, maybe previous heart attack, with a lot of lung issues, And also people that are generally older in population, like 70s, 80s. So those people tend to, among all the age groups, they tend to not do so well as compared to the younger people. So yeah, for those people, we will go more aggressive. There are some medications, antivirals that we can use, but the significance of the antiviral is yet to be determined. I think the trials are still ongoing. And I suppose another thing of great interest would be vaccination. Yeah, so vaccination, on the other hand, is still in the pipeline, but for it to be developed, it needs to go through multiple testing process. So it won't be out for the foreseeable future anyway. So yeah, I think
That's very illuminating, actually, Dr. Lau. Very illuminating. Most of the normal rakyat don't know anything about what you just said, the different stages and so forth. Let's talk a bit about the difficulties that we hear about that the frontliners are facing now. Lack of equipment, particularly personal protective equipment or PPEs. Can you shed a bit of light on that?
Okay, yeah. Let's just go with the PPE first. So, so PPE, actually, there are multiple types of PPE depending on what we are trying to prevent the spread of. So, in general, when someone says PPE, they just mean anything like face masks, gloves. But actually, there are two main groups, because in order to know what we are using, we need to know how it's spread. And based on what we know right now, coronavirus, as in SARS-CoV-2, is spread primarily through droplets. So basically, things that can be spread up to 1-2 meters, like if you were to cough, if you were to, discard your sputum somewhere, or like, if you have somehow cough onto your mouth, cough it onto your hand and started touching random surfaces, those surfaces would also have droplets on them. So you can spread through that as well. Now, for those droplet transmission, which is generally for most people in the public, face masks can prevent direct spread onto you. So say if like Jay Sham, if you were to be in front of me right now in like a 1 meter distance, if I were to cough right into your face, you would have immediately been infected if I have COVID. You understand what I'm saying? If I were to spread straight into your face. However, if you have the face mask on, what the face mask does is it prevents direct inoculation. Like you can't just directly cough into my mouth with the face mask on. So it filters that. However, what it doesn't do is if you were to cough into me and somehow was on my shirt and I were to touch it and then rub my eyes with it, then that's a different story. Okay. So now in terms of what's saying called droplets precaution, we have mainly the gown. It's just a very tiny piece of apron. So again, prevents direct splashing onto my shirt. Face mask and gloves. That's about it. That's the most basic precaution that we have for COVID. However, in the hospital setting, we need to be a bit more extensive, because there are ways that we can generate airborne transmission, which means the virus itself can be aerosolized, which means it's turned into gas in a way, kind of gaseous form. So it's floating in a room for a bit. For those settings, so certain procedures like nebulizing, things that you give for kids when they're having like some wheezing episode, you give them like that smoky thing. So that's a nebulizer that actually aerosolizes the virus. In that setting, we need full PPE. And when we say full PPE, we mean face mask, N95, face shield, N95 face mask, together with like a completely impermeable gown, which is really, really hot, by the way. And it's a real hassle to put on. Like it takes like minutes to be ready, and each time that thing has to be discarded. So in that setting, those equipments, as in like those things that I have just described, they're actually not free flow as of supplies. In the past, when I just started to practice in PPOM, the thing about us is whether we like it or not, it's just part of the job that somehow, unfortunately, we bring stuff home. and face masks at that time could be one of them. So it's just somehow in your scrubs, it was in your pants, and it was improper improper disposing of the equipment, but it's somehow brought home. And somehow you have more than one, and that's fine. Currently, in our hospital setting, we actually log every, as in like we have to register for every piece of face mask that was used. That is the, that's to show that how much we have left in the supply. Like we no longer can provide everyone with just like free flow face masks, free flow gowns. That's just not possible anymore. So yeah, so face mask is now deemed to be required and compulsory for every single staff in the hospital, as long as you're in a clinical area. But it is not unlimited, including like gowns and all that. The thing is, I have yet to see, or I've never seen anyone wearing like plastic bags, that kind of thing, in the hospital, like what people have been sharing on WhatsApp. So I guess that's all I can say.
Okay, thank you, Dr. Lau. Now we're going to move on to, we've got quite a few questions that have been coming on our live chat actually. So we're going to try and work through them with the time we have left. Okay, from Mr. Lukman. He asks if you could bust some of the most common myths about COVID-19. Maybe some that you've come across that factually it's not true.
Okay, hot water doesn't kill coronavirus. Yeah, so thank you, Dr. Lukman. Thank you, Mr. Lukman. So hot virus doesn't kill the virus. So actually don't try it, because what hot water or really hot water can do is it can scour the internal lining of your mucous membrane, and actually that inflames the area and might cause an easier spread as well. So don't do that. Second, wearing a face mask or wearing a glove actually doesn't in a way stop the spreading. What it does is it can remind you not to touch your face with the gloves, or not to rub your eyes with your gloves. So you put them on, and it's easier for you to just discard the glove, basically with the surface facing outside, and throw it away. So it's easier for you to discard them. It's easier for you to prevent touching yourself, but it doesn't actually stop it. So if I was wearing a glove and I were to touch on the doorknob where there is coronavirus lingering on the surface, I would have had it, and if I were to rub my eyes, I would still get it. So yeah, I can't think of anything, unless there's anything in particular that was brought up.
Well, your answer actually touched on the next question, but from Chong Lai Kiat. He asked, should we be wearing masks in public if we aren't symptomatic?
Okay, thanks, Lai Kiat. Okay, so I think that's a very good question. As far as I know, and you can correct me on this, as far as I know, there isn't like a specific rule from the government that states that you must wear a face mask. Now, the face mask, as per what WHO, the World Health Organization, suggests, it only works, as in like they only put it compulsory for two main situations. Either A, you have symptoms yourself and you want to prevent spread, and that is very good, because that's what we do for people that are in the hospital as well. If there are any symptoms, we put face masks on them so that we prevent them from spreading to everyone else. And B, the second situation, is where you are a completely healthy person and you're caring for someone that likely has the virus. And then I think it's fair as well, because you're preventing yourself, not the patient, but yourself. So for general public, I think it's good that if you have a face mask on, it's good. It can in a way add an extra step for you if you were to touch your mouth and rub your nose, which it's really hard to do, because in general, and people don't realize it, you touch your face very, very frequently. And I probably have touched my face multiple times throughout this video as well. So having that mask actually deters you, but it doesn't stop the spread. And if you don't wash your hands frequently, and if you don't wash your hand with either alcohol or like alcohol hand gel or soap frequently enough, it actually makes not much of a difference, to be honest. Like, other than what I've said earlier, by direct spreading. So it's not compulsory.
hygiene and social distancing is probably
Yes, it's really
more effective.
and also more economically friendly, frankly, because I think everyone is aware that face masks is actually getting very expensive, and with people, I hope not, but with people keeping them at home, they'll make the price worse. So yeah, social distancing is very important. It really works, and hand hygiene really makes a big difference. So if you don't do that, if you're just hoping that wearing a mask will make a big difference, and it's the magic pill, it's not. Yeah.
Thank you very much for that answer. I think that helps a lot with people's wondering about this particular issue. Okay, we have another question coming up here from Coach Alex. We are halfway into the current RMO, and already people are starting to talk about whether it would be extended. What are your thoughts? Do you think the RMO should be extended or would be extended at this point?
I think it's hard to say yet. As far as what we know right now, it's actually the whole point of RMO is to reduce the spread. It is logically almost impossible that we can stop the spread immediately, with a complete halt. However, we can stop the spreading. And as far as what data has been showing us, it looks like we are at the start of things starting to look good for us. So in a way, we have been having numbers of new cases. Also, I think if you were to look at cases, you should look at number of new cases. So the number of new cases have been pretty much stagnant between 100 to 200. So I think that's good. We did not spike up to like thousands, which is what would have happened if RMO wasn't in place. So I think it worked, but for it to really last how long more, I think that's a good question, but I can't give you the answer to it, unfortunately. Yeah, I think we would know very soon, in about 10 days time also. Yeah, in about a week time.
Okay, well, hopefully that won't be the case, and we will get out of this sooner rather than later. Okay, a lot of questions coming up here, so we're gonna just try to get through them. Miss Jasmine asks, as a foreigner, because Miss Jasmine is from Iran, asks, as a foreigner, will she get the same treatment as locals from PPUM?
Okay, so if you were to come in with, I presume you're saying that if you have symptoms. So if you have symptoms and if we were to get you tested and admitted, your treatment will be actually very similar to what we are doing to our Malaysians. But in terms of payment, that may be a bit different because PPUM is not a government hospital. It's not a pure government hospital. There's a private side to it. So in a way, it's most things that PPM has is slightly different in terms of payment wise. So I think if you're just asking in terms of management and just how you're being treated, it will be exactly the same. But in terms of finance, I think that would be a bit different, and I don't actually know what is the difference in pricing. So yeah, that's all I can answer.
But it's good to know then, regardless of foreign or local, treatment is treatment.
Yep, treatment is treatment.
Okay. Next question from Mr. James Keaton. Do you think Malaysia could be affected as badly as the US or other parts of Europe, like Italy, for example, that we're seeing now?
Thank you, Mr. Keaton. So I think what people need to understand is we don't actually know exactly the spread and how the graph truly is, because numbers are underestimated, as we all know. Now, the issue is we need to understand there is a for all these kind of diseases, things that can be contagious, we have a way to measure how contagious they are. So for measles, it will be probably about one person spreading to about 15, averagely 10, 15. And it gives you an R naught number of 15, around there. For coronavirus, the number is much smaller. It's about 3. Now, if you have, in simple terms, what it means is, if you have a population of completely susceptible individual, which we can assume that we are, every person that is positive can averagely lead to 3 new person that is positive. That's what the number means. Now, if there is a bigger number to begin with, then those number will duplicate and 3 times itself a lot faster. Because our number was acted upon fairly quickly, and kudos to the people in KKM, we were acted on relatively quickly. So we managed to actually keep it fairly low in terms of numbers, as in we're not dealing with hundreds of thousands yet. So yes, our healthcare is under a slight strain, but we are not in a point where it has, we have not reached the point where the curve has passed our accepted line yet. Yeah, if that's what you're asking. So
Okay, that's good to know. But of course, we still have to be very vigilant and keep up with the measures that you just mentioned earlier: social distancing, keeping good hygiene, and so forth. Okay, we have time for just one more question, and that's going to be from our founder mentor, actually, Datuk Frida. Datuk Frida asks, can the wind blow the virus further than 1 meter, given that's supposed to be the safe distance? Is that a possible scenario?
Thanks, Dr. Frida. Dr. Frida. So, what we know is for the droplet, so the main spreading method, which is droplet, yes, it can deviate slightly, but not to the extent where from 1 meter becomes like 10 meter. So long as you stay in like social distance, like a comfortable 2 meter distance, which means if you were to put out your hand and the other guy puts out his hand, and if you can't touch each other, that's a relatively safe distance. So so long as you really abide to that and really try your best not to get into gatherings where distancing might be a bit difficult, I think you are being very safe and responsible to yourself and everyone around you.
Okay, that's very good to know as well, because there's a lot of confusions and whether the method of transmission and whether it's something that we need to be worried about, actually. Tell you what, actually, we have just enough time to squeeze one more question, actually. And this is from your former principal, Dr. Lao, Puan Aimi.
Oh, okay.
Puan Aimi asks, quite a number of COVID-19 patients have been discharged, as KKM has announced. Are they still susceptible to the disease as well? Can they be reinfected?
So as far as we know right now, among our population, we have yet to have a reinfection of someone that is healthy. So like most virus infections, when you do develop your your adaptive immunity to it, in general, we can assume they won't be infected, as in they won't develop the same illness again. Just like how currently we don't actually have any evidence that people can do so. However, we cannot fully rule that out because anything is possible. So I can't confidently tell you that it won't happen, but we don't have evidence of it happening yet. If that answers your question.
Okay, I'm pretty sure it does. Okay, ladies and gentlemen, Cempakans, we've come to the end of the episode 4 of our Cempaka at Home webinar series together with Dr. Lao Jiaying. Please, I'm sure all of us feel the same way, that we express our heartfelt gratitude and thanks to people like Dr. Lao on the front lines, battling this disease while all of us stay at home and under this RMO. Thank you so much, Dr. Lao Jiaying, for spending your time with us this afternoon. We wish you the very best. And once again, thank you so much for your hard work and sacrifice from us in our time of need. On behalf of all Cempakans, thank you.
Thank you very much for having me as well. Thank you.
Please join us in the next episode next week. Stay tuned for the next series on the Cempaka at Home webinar series. Thank you, Cempakans.